our doula. Great, thank you. The doula integration work that PMC, or Primary Maternity Care, has been helping us with, and who will be presenting today. We are going to be meeting next week. We do want to talk further about the launch of the bundle as well, and where that stands, and what next steps are. So we have scheduled another follow-up for May, and look forward to that conversation as well. So just given our time, I know apologies, a little bit limited. I'm not sure, Tiffany or Claudia, if you guys are sharing, but hopefully screen share looks like it's live. So we'll defer to you, and we'll pass it over to get started.
Great. I don't know. I actually don't know who's going to be sharing slides, but I'm going to kick us off once. Can somebody pass the co-host, I guess, to myself or Claudia?
I think you should be able to share without that.
Yep.
Yeah.
Julia, can you get the slides up?
All right.
Yeah, I'm happy to do so.
So while those are coming up, I'll just get us started and introduce myself, and then I'll let my team say hi, and then we're gonna move through some of this content. My name is Amy Romano. I've been part of this group as a stakeholder from the beginning. And so I've been involved in this work as someone who's been a midwife in this state and who's been involved in payment reform initiatives and care model innovation initiatives in a lot of other states. So separate from that, we also have been partnered with DSS and CHNCT, as well as our partner on this work, Health Equity Solutions, to help with the implementation and integration of doulas into the bundled payment model. And so this is a contract that we've been working on, and we're going to be presenting as sort of a part way. We're still working on the work, but we're going to be presenting our landscape and some of the plans for implementation as they stand today. So we'll go ahead and go into the next slide, which I think has an agenda on it. So we'll talk a little bit about the goals of this work, and we'll go through kind of the key recommendations up front and some of the decisions that have been made up to this point, and so frame that up, and then go and do more of a deep dive on the landscape analysis. We've done a ton of assessment work and been talking to a lot of people around the state. So we have summed up that information, have a lot of data to share back, and then we can talk in a little more depth about our implementation plans and next steps. So before I move on from here, I just want to pass it to Claudia, and then maybe we can just pass it through the team for each individual to say hi and share a little bit about your role in the project.
Hi, good morning, everyone. My name is Claudia Jennings, and I am the project manager for primary maternity care. I do operations work for the organization, and my background is in practice management. It's nice to meet you this morning. I'll pass it to Darlene.
Good morning, everyone. My name is Darlene Turner, and I am a doula, and I am the doula programming manager for primary maternity care. And I have been working on this project, getting the workflow, the training, and the recommendations for doula practice. And am I passing it to Julia?
Hi, good morning, everyone. I'm Julia Cogdell. I'm the Operations and Programs Associate at Primary Maternity Care, and I really work on a lot of the admin and internal and project support. And my background is in medical social work. And I will pass it to Health Equity Solutions, Itcha.
Hi, thank you. Hi, I'm Itcha Pradhan with Health Equity Solutions, and I'm a policy and advocacy specialist. And we have partnered with PMC to do work on focus groups, landscape analysis, and just overall.
Great. So we can go ahead and move on to the next slide. So this project overall is about assessing the doula landscape in Connecticut, understanding what the capacity is as we bring online a doula benefit for participants in the bundled payment, and to understand the network adequacy and what infrastructure is in place And then to do the work of planning the bundle integration, which will implement along with the rollout of the bundle later this summer. So where we are today and what we're presenting are primarily these two in pink. So a doula landscape analysis, which kind of brings together a bunch of assessment work that we did to kind of understand the state of affairs as it exists today and what the areas of opportunity and infrastructure challenges look like. And then to develop a doula workforce development plan. So that's something that we have developed and will incorporate some of the outcomes and recommendations of that in this presentation today. And then we're currently working on these second two, which are to turn these recommendations into implementation resources for integrating doulas with clinical practices, because as we'll get into in a moment, this is really about the bundled payment model being a way to engage doulas as part of clinical practice teams. And so we need to understand what that integration looks like and provide both practices and doulas with some resources to ease those transitions and make that teamwork happen more smoothly. And then to also build out or, have plans for what will be needed to do the implementation work of credentialing doulas, administering the benefit, and how the payment will flow. So those decisions are being currently developed and will be rolled out in presentations to different stakeholders later this late spring in June. So I will come back to these recommendations. They'll make more sense once we have the context of the landscape report, but we wanted to put them up front because we'll be talking for a while if people need to drop and just to kind of understand where we stand. So one of the key recommendations coming out of this work is that we really need to put some emphasis on workforce development. There's some really good foundational work. There's some amazing doulas in this state that are very well organized. There's a reasonably diverse doula workforce in this state, certainly compared with what it's looked like in the past and in some other parts of the country. But if we're talking about doula care being the standard of care and really being available to everyone and being provided equitably, meaning to really direct these resources to the communities that are most impacted by the inequities in our birth outcomes, we need to be really thoughtfully developing the workforce so that we have a workforce of doulas that match the cultural, linguistic, and just kind of care needs of the population and of all populations, because everybody gives birth in this state. So there's a lot of work to do to just grow the workforce in general, and also to grow the workforce strategically to meet the need and to address the inequities. Reimbursement is something that needs a lot of careful attention. It's going to be one of the biggest drivers of participation in the doula benefit, but for doulas themselves, which then will drive the accessibility of the benefit for members. So there's work, and I'll pause here to just talk about, which we'll get to in a little bit more depth, but I think people understand that there's work going on to certify doulas through DPH, but that is requiring a legislative fix, which is underway and looks like it's moving forward, but needs to kind of play out. And so we have to create, in the meantime, some work that hopefully can inform and mesh nicely with what DPH ultimately comes up with. But we can benefit from a bunch of work that's already underway as well. So we're aligning with the work that DPH has been doing and is doing in anticipation of certification, but we need to create some interim infrastructure for this pathway of paying for doulas through the bundled payment. So we are advising to again leverage what's happened already at DPH, which is primarily the development with a lot of doula engagement and draft competencies of what should qualify people for practicing as or being a doula for the purposes of reimbursement in Connecticut. Aligning the payment rate with national trends. So we've seen from the early states that implemented doula benefits that they set the rates way too low, and it both didn't attract doulas and also set the tone of that it wasn't valued and that it wasn't, there wasn't a real intention around making it accessible. And so we've seen finally some payment rates that are more in line with workable, livable wages for doulas. And so we want to continue that trend and be part of that, vanguard of paying doulas what they're worth. Pursuing direct reimbursement pathway along with bundled payment benefits. So this is what I was referring to earlier, that there are now sort of two pathways that are happening at the same time through this bundled payment and also through the legislative action that's taking place. And we need both of these pathways to be functional and for them to also work work well together and for us to learn what we need to learn to understand the best ways to pay for this benefit. Practice integration. We believe that based on what the workforce currently is and what it's going to take to sort of work out some of the implementation details and seeing what's happened in other states that have turned this benefit on in terms of what their utilization rates have been, we expect and we'll be planning for less than 10% utilization in year one, with a hope obviously of growing that, because we believe certainly more people than that and ultimately everybody should have access to this benefit. But that's really, we've seen sort of single digit utilization in other states as the benefit comes online. Encouraging adoption of doula policies, and we'll talk more about what those can look like, just to really clarify the role of doulas and how they fit into the overall team providing care. Providing member and provider education. There's just a lot of education that everybody still needs about the role of doulas, the scope, how doulas are different and similar to midwives and so on, and community health workers. Encouraging providers to work with a diverse pool of doulas. So again, we need doulas to help support culturally aligned care, culturally matched care whenever possible. The last item, considering a third party intermediary, is really necessary for doing the kind of work of all the back end details of payment for a service like doula support. So doulas want to be, providing support, not doing administrative functions. And so we've seen some interesting examples in other states of third parties or collectives or technology partners that can play a role in helping implement this benefit. So we're going to kind of come back to all of these recommendations, but that is the executive summary for those who were interested in that. Next slide. And then this is what the payment pathways look like at a glance. And so these two columns on the right, the first is what we're talking about today, which is through the bundled payment. And then the column on the far right is direct fee for service. So that would be the payment function that would become available if certification passes through the legislative fix that I referenced earlier. So versus bundled payment, which can roll out before and regardless of the legislative fix, and will roll out with the bundle itself. So, so just going down each of these items, the DSS, because it requires legislation for DSS to credential or enroll doulas directly, we will not be doing that. They will essentially enroll with the provider practice, which would be paying for the doula with the funds provided from DSS. And so ultimately, again, with certification, that will change. What that will look like is still being worked out. And there's some preparation work that's been happening ahead of the legislation, but that will continue once that passes, or if that passes. Certification, again, DPH has done some groundwork on this. So we've been using, PMC has been looking at those certification recommendations and trying to make tools that will help practices assess doulas, assess doula training programs that doulas might have attended, to understand, what are the qualifications of doulas, because one of the things, as we'll see, there's a lot of different training pathways for doulas and it's a lot to sort through. Ultimately, that function will sit with DPH, and there's a group that is assembling to advise on those details. The population served through the bundle will be Husky bundle payment participants. So I'll defer or refer folks to the overall bundle design around who that is, but it's, practices, I think it's that have the threshold number of 30 Husky births per year and a few additional population characteristics. Eventually, through the direct fee-for-service pathway, any Husky member will be able to access it, and that's one of the major benefits of that pathway. The payment rates and covered services are still to be determined. What we can get back to this and talk a little bit more about, what some decisions that have been made, but we'll get a little more into the landscape analysis before we return to that. Next slide. So we'll go ahead and advance again to the next slide. So just briefly, we have been spending the last several months doing a lot of work to understand what's going on with doula practice in the state. Who are the doulas? What are their characteristics and so on? So we fielded a survey. We got 55 responses from doulas who practice in Connecticut. We've also been holding focus groups and stakeholder interviews and participating in a number of activities, both state-based and national, that are looking at sort of models of payment and implementation of doulas, and in particular, community-based doula models that are addressing health equity through compensation and payment models in Medicaid. Next slide. And throughout this whole project, we've really been working to thread equity through all of it. We've been looking at all of the data that we have access to, the survey data, our focus group data. We've been stratifying and looking at by race and ethnicity. We've been outreaching to leaders in the state and nationally who, again, are working in doula models and who understand the structural issues around payment for doulas in Medicaid, and that address different populations with different language needs, programs that are trying to provide racially aligned care and so on. So we've really been tapping into a lot of great work that's been happening both here and nationally to bring those insights into this project. And talking also to stakeholders that are currently reaching these populations. So there's a lot of community organizations, community health worker models, and other kinds of stakeholders that have good access to the populations that we're trying to reach with the doula benefit. We've been providing folks with opportunities to engage in our focus groups and surveys and so on in multiple languages with interpretation as needed, and just really trying to center both doulas of color and birthing people of color in this work, and making sure that we had members' voices as well as doulas and providers' voices and all stakeholder voices, but we made sure that we talked to Husky members themselves as part of this work. Next slide. So let's talk about what we've learned. You can go ahead to the next slide. And I'm going to pass it to Itcha to talk a little bit about the demographics and starting with where the doulas are. Itcha.
Thank you. Thank you, Amy. So we had great insight from doula participation, but before we dive into that, I wanted to walk us through demographics to see where and who we engage with. And as you can see here, we have areas with highest number of births reported in Bridgeport, Waterbury, Hartford, New Haven, and the second highest in New Britain, Stamford, and Danbury. The rest are spread out across the state. And even though we see the spread, doulas cover the whole state because they're able to travel, although they are more physically concentrated in the same locations where the most births happen. Next slide, please. So here we have self-reported race, ethnicity comparison between doulas and Husky Health members. For this, as Amy stated, our teams actively decided to use Connecticut race, ethnicity, and language data standards and granular categories. We have a significant number of Black and white doulas. However, they are sufficient for current demand and not for projected demand. Although we see the need to expand the doula workforce overall, we really saw some gaps in specific racial and ethnic groups as well as language groups. Next slide, please. So here we have a map of all the participants we engaged with in focus groups, interviews, stakeholder interviews, and such. And outreach for this data collection for the map consisted of emails, text, and phone calls to reach out to engaged participants. We sent an initial email first and at least 2 reminders. We had the highest number of doulas and focus groups and survey from New Haven, Bridgeport, Hamden, Middletown, and New Britain. And we had the highest number of clinical providers from Hartford. The towns reported by Husky Health members were more widespread, as you can see on the map, although we had a few more from Hartford and Stamford. You can also see stakeholder groups marked in red on the map. And I will just pause here for a moment so you can take a quick look, but I believe you can reach out to Claudia if you'd like to take a look at these details. Next slide, please. Thank you. So we also surveyed doulas of the languages they reported that they speak most fluently, and 7 of them reported being bilingual. Again, we see some gaps in specific language groups, calling into attention the need for diversity in the doula workforce. Next slide, please. And here we also surveyed doulas on gender and sexual orientation. And we can see that 98.2% identified as women and 7.3% as non-binary. Likely there was an overlap. And looking at sexual orientation, 2/3 of the doulas identified as straight. And we also have bisexual, lesbian, queer population. Now I'd like to hand it over to Darlene. Thank you.
Good morning, everyone. I'm going to talk to you about the doula practice characteristics. Next slide, please. So as you can see from this slide, that doulas are really practicing in a wide array of disciplines and serving a wide array of people. So that's a really good thing for Connecticut because it shows that the workforce is very diverse and can serve a diverse population. Next. And the type of support is pretty standard, but we did see, we had quite a few who provide bereavement support as well as abortion support. There are other types of doulas like death doulas and what have you, but we chose to focus for the purpose of this just on the perinatal doulas. So of course, most are supporting births and prenatal appointments and then the postpartum support. Next, please. And again, you can see that the large majority of the doulas are serving in the hospital setting, but we did have a significant number that are doing home births. So one thing that I want to bring to people's attention is there is a large connection between doulas and midwives. And some of the doulas that we spoke with were saying, oh, sorry. I'll try and speak up. Some of the doulas that we spoke to were saying, midwives were saying that they really felt comfortable working together. So there is a lot more when we look at the data, doula midwife kind of relationships and cohorts. So what we're going to want to do is increase those relationships between doulas and obstetricians and hospital practices. And there's still a fair number of doulas serving folks in freestanding birth centers. So that is something that we do want to continue and increase. Next, please. So what we came away with is that there is still a lot of education that we need to have for physicians, midwives, and Husky Health members, because there was still some vagueness between what doulas do and what midwives do. We did find that people did understand that they provide emotional and informational support, but there is a lot of physical and social service support that's provided as well. So we want to provide education there. Physician and midwives reported that patients do feel more comfortable with doulas, and then the Husky members themselves were saying, especially those doulas that share cultural and linguistic characteristics that they did. Husky Health members wanted to receive more education from doulas on all sorts of topics with pregnancy. So as we're building the workforce, we want to make sure that we're equipping doulas to share that kind of knowledge with the members. And again, they valued bilingualism and technology. I wasn't sure if that means, I think, being able to text and converse with their doulas, and then massage and comfort measures. Next. So I'm going to be handing it over to Claudia and talk about network adequacy.
Thanks, Darlene. Next slide, please. So next we wanted to look at the capacity of the current doula workforce once we understood the demographics and kind of the way that they're serving. So the first thing that we looked at is the annual birth volume of the doulas that we surveyed. And the responses were from people who had varying levels of satisfaction with their volume. Some wanted to work more and take more clients, and some wanted to work less and felt like they had too many clients. And some of them were really satisfied with their current volume. Of the doulas who were satisfied with the volume of patients that they were serving, the average was 27 births attended per year. And of the doulas that wanted to work more, their average volume was 15 births per year. The next thing we wanted to look at were the percent of people that were interested in increasing their volume versus keeping it the same or decreasing it. So what our survey revealed is that more than half of the current doula workforce was interested in working more. That's the dark purple in this graph, which is about 60%. Not surprisingly, what we found is that the people that wanted more births were doing on average fewer births overall, and the people who wanted to do the same number of births or fewer births were doing on average more births. And our conclusion from this information is that there is existing capacity within the doula workforce in Connecticut to take on more births. And the next question that we had is, are doulas interested in serving Husky members with that existing capacity? What we found for that question is that nearly 3/4 of the doulas surveyed were extremely interested in serving Husky members. That's the dark purple in the graph. And if you include in it doulas who were somewhat interested in serving Husky members, that leads to about 87% of the doulas surveyed being interested in working with Husky members. And that combined reinforced our finding that there's definitely existing capacity within the doula workforce that can be used to serve Husky members when doula services become a covered benefit through the bundle. The next question that we had is, what factors would influence a doula's decision to participate in the bundle? And what we found are that the most important programmatic factors that influence participation are the amount of compensation, the ease of receiving that compensation, and the availability of additional training to meet the specific needs of Husky members. The available training came up in the form of specific things like violence prevention, but also in doulas wanting to be able to run their business more professionally and feeling like they could benefit from small business specific training. Some of the other factors that doulas mentioned were the ease of being accepted into the program, getting paid in a timely manner, easy claims and billing submissions process, and of course, not too much paperwork. A lot of doulas noted that they're small businesses and they have limited time to devote to administrative tasks, which is no surprise. And also we know that many practices feel like they're also small businesses and don't want to spend too much time on paperwork. Next slide. So we wanted to take all of these findings and develop a network adequacy estimates based on them. And to do so, we needed to extrapolate some workforce assumptions. So after reviewing the survey data and comparing the survey responses, meaning the 55 doulas that responded, to other sources of information about doulas in the state, like provider referral lists, public websites that list doulas that are working in the state, we estimate that the total current populations of doulas in Connecticut is about 100 to 150 people. We know that not all of those doulas will decide to serve Husky members, and that the doulas who do choose to serve Husky members will optimize their payer mix meaning they'll take as many Husky members as they want to or can afford to based on the final program structure and the reimbursement rate. We think that about 50 existing doulas in the state will participate in the program in year one, and their volume will be dependent upon the referral pathways that are created. We're using 36 births a year or 3 births a month as an average doula caseload based on the survey responses and what we know about doula practice. So using these assumptions, we developed 3 workforce scenarios that we want to share. For these scenarios, we used an average of 15,000 births. We know that the actual Husky birth number is a little bit higher than that. We also know that not all Husky members will qualify for the bundled payment due to the limited exclusions that do exist. So we're using 15,000 as an average. Our first scenario was at 4% utilization of the doula benefit, which would mean that 600 Husky births would be attended by a doula. And if those 50 doulas that are in the current workforce were each taking 1 birth per month, that would be just enough to cover those 600 births. And if those doulas attended 2 Husky births a month, then there would be more than enough doulas to cover that number of births. The second scenario was at 5% utilization of the doula benefit. That would mean that 750 births in Connecticut were attended by a doula. And with 50 current doulas taking 1 Husky birth a month, we would need 13 more doulas. And if those 50 doulas were taking 2 Husky births a month, the current workforce could meet the demand. So those 2 scenarios are more likely, and the workforce is pretty spot on for that level of need. And then we looked at a 10% utilization scenario. So at 10%, there would be 1,500 Husky births attended by doulas. And if those 50 current doulas were taking 1 Husky birth a month, we would need about 75 more doulas. And if those 50 doulas took 2 births a month, then we would just need about 13 more doulas. The numbers are estimates, but they really help us to understand how far off the current workforce is to meeting the demand at the varying utilization and caseload levels. And while we expect that for what the utilization will be in year one, the current workforce can meet it, we know that workforce development is extremely important. We'll talk a little bit more about doula training in the next slides, but what's important for everyone here to understand is that the pathway to becoming a doula is much shorter than other professions, and it's possible for interested people to become doulas within 6 months. And so with this in mind, we feel like scaling the doula workforce is very achievable. And we know that there is interest from people to become doulas. And so we know that there's a lot of workforce development work to be done, but it is extremely achievable. And I will pass it off to Darlene to talk about doula training.
So we're going to go on to the next slide. First things we want to say is that 100% of the doulas that we surveyed had some formal training, whether it be one particular certification, or most of the doulas had done multiple different certifications with different organizations. Of the 55 doulas that we had, they came from 26 different doula training programs, and the most common were DONA, Earth's Natural Touch, Madriella, Childbirth International. And 87% of those trained were in fact certified. I want to stress that there is wide variation in the different programs. There is no standard doula training. So when we started looking at this, it was like, well, how do we quantify what doulas know? Next. So we went through the different programs. We took the most common ones that came up in the surveys, and we looked at what their actual curricula showed. And this slide in particular was mostly taking the data from their websites and their publicly available data. We've actually drilled down more, and that will be presented when we do the full-on workforce development plan. But you can see, some are 2 months, some are 14 months, and there just isn't standardization, but they all cost something. And that is why we have to make some allowances or understanding for doula training. Some programs take just a few doulas per cohort, others are unlimited. It can be any number of people. But the good news is there is the capacity to train however many doulas that we need and to build the workforce. Next slide, please. Those were the Connecticut programs, excuse me, I should have let you know that. And these are the international programs, which are the most common were DONA, Kappa, Madriella, and Childbirth International. And again, these were more likely to have rolling registrations and no specific number of people who could train at any one time. But again, they were a little less specific because they trained so many people globally. Next. So what we found through the focus groups is that doulas want to increase their training, especially on managing emotional issues, things like substance use, intimate partner violence. They want more financial literacy and work on the business of being a doula, informational management, data management systems, and then just general pre and postnatal care. Again, the biggest barrier to education is the cost. People just can't afford to shell out, $500, $1,000 for a course. And then also time, because a lot of doulas are working full time, either as a doula or in another job. So it's hard to take the time to really complete the training. And then we had a lot of doulas saying, well, they didn't know where they could get certain trainings. So in terms when we ask Husky Health members, a lot of their concerns were, well, we don't really know what doula training is. So again, there's going to be more education for the Husky Health members as well as the providers, because we did have some providers who expressed that same concern. Next. And so I'm going to pass it for partnerships and affiliations.
Thank you, Darlene. So for partnerships and affiliations, we also asked doulas and clinical providers in our focus groups what existing partnership has looked like for them and what they envision for future partnerships. So as you can see, overall, providers and doulas were interested in working together and saw both benefits and challenges. Clinical providers shared that doulas simplify their work by keeping track of patients and learning things about them that could be easily overlooked during clinical visits. And they also shared that collaboration among doulas, medical practices, and hospitals could lead to smooth delivery and post-delivery procedures, lower mortality rates, and parents just being better informed regarding infant care. Benefits and challenges showcased here, shared by both doulas and clinical providers, showcased to our teams that more education would be helpful to the general public and specifically providers and Husky members who would be the ones to utilize doula services on what a doula is and what they do or do not do. Next slide, please. So here we have doula and clinical provider perspectives on affiliations and policies. There are currently very few affiliations that exist between doulas and providers. There are only 2 known hospital-based doula programs in the state of Connecticut. And doulas report that they do create referral relationships with providers who they have experience working with and have seen those relationships increase their referrals over time. But there was widespread interest in developing more stronger and formal relationships and an eagerness to learn. Whereas providers shared that they have referral lists but no affiliations, and they were unfamiliar with specific programs in their area, but they also shared an interest in developing those relationships and affiliations. Providers also said that they historically did not refer to doula services due to costs for the patients. Next slide, please. So now talking about utilization and outreach of doula support by current Husky Health members and in Connecticut more generally. Next slide, please. So we asked Husky Health members about their experience and preferences in accessing doula support and what could be done better to improve access. Again, cost was the primary factor that prevented Husky members from having doula support. What I would really like to highlight here is that 88% of the Husky Health members said they would want doula support if it were provided to them as a covered benefit. Also, half of them would prefer receiving a referral from a clinical provider to access those doula services. Now, I'd like to hand it over to Claudia to speak more on the current utilization.
Thanks. So our estimate is that the current utilization of doula services is very low among Husky members, likely less than 1%, but we can't know for sure because most practices haven't historically tracked this information. Some practices do report overall estimated doula utilization exceeding 25%. And our findings were that practices that have midwives usually had higher doula utilization. And a lot of practices said that they estimate their utilization to be between 5 and 25%. Although, again, this isn't something that they're actively tracking in most cases. And so these are kind of estimates in terms of how many doulas they have attending births. We also looked at utilization of doula benefits nationally. We looked at the two most seasoned doula programs that have Medicaid payment. Those are in the states of Minnesota and Oregon. Both states experienced very low utilization, which was influenced by their extremely low reimbursement rates, enrollment hurdles, and gatekeepers in the form of payers with strict certification rules that didn't reflect the full scope of doula training options and as well as physician supervision requirements. On the opposite side, we saw that Rhode Island rolled out a process very recently that some of you may be familiar with, that was doula-led and informed, and they've had a lot of early success in launching their benefit. It just launched last year, but in the first 6 months, they served 100 families. And for context, in the first 6 years of the program in Oregon, 200 births were attended by doulas as a covered benefit. And in Minnesota, for the first 6 years of the program, 850 births were attended by doulas. The major difference is that the original rate in Oregon was $75 for the entire doula benefit. And in Minnesota, the original rate was $411. And so, you know, these rates are obviously quite low, and for most doulas, it wasn't worth it to go through the enrollment hurdles for a rate that was really not sustainable. Whereas in Rhode Island, the max reimbursement rate is $1,500, which starts to become a much more reasonable market rate for doula services, although is still lower than what doulas can charge in the private market. Next slide. Although cost was cited as a major barrier by Husky members, we also learned that there's a big awareness and education gap for providers and Husky members related to doulas and their scope of practice. A lot of doulas market their services through social media and word of mouth. These are very small grassroots organizations, and understandably don't have complex marketing operations in place. Some doulas have developed referral relationships with providers, though they're typically not formal. And we found that a lot of clinicians had ideas about how they could work more closely with doulas, but overall needed more education about doulas. And that goes back to the utilization, and even the most, even the practices that have the strongest doula relationships are seeing just about 25% utilization, but more practices were around the 5 to 10% mark. And so providers just really need more education about what it's like to work with doulas and what role the doulas can play. The last thing we wanted to look at related to the landscape analysis was the administrative and data collection infrastructure. We found that the landscape was highly variable, often related to whether a doula was self-employed working completely independently or whether they were part of an organization. We saw that existing charting and record management systems ranged from none to using a written method like a notebook or spreadsheets, and then we found some doulas that are using formal software. Some of the platforms that are in use only support portions of the administrative workflows, whereas others are more robust. And we also found that related to administrative infrastructure, providers agreed that doulas should chart electronically, but only wanted to have visibility into the charting if there was a clinical need to know. but generally didn't want to or feel like they needed to be privy to all of a doula's encounter notes from their entire care with the patient. Next slide. So the clinical outcomes reporting was also varied. Doula programs based their reporting on either the requirements from their funding source, like grant requirements, or items they had a personal interest in. And we heard a lot of interest from doulas in having stronger outcomes data and questions about what the most important outcomes to track would be. So this was important for us in seeing that doulas are motivated to start collecting data in a more meaningful way, and is important related to the bundled payment because they will start to need to track some of this information. Next slide. So overall, for the purposes of integrating doula services with clinical care for the bundled payment, providers noted that charting needs to occur electronically for the ease of information exchange between providers and doulas. Providers don't want to review every encounter a doula performs, and they're concerned about the administrative burden of engaging more deeply with doulas because of the uncertainty around what a program could look like and what's involved. Doulas had similar thoughts voiced from kind of their own lens, which is that doulas want to share what information is necessary, but don't want to share all of their client information. They definitely want to retain ownership of their client data, sharing, again, what's relevant as needed with their collaborating practice. And they want to maintain their professional independence as non-clinical members of a patient's care team. These factors were all really important for us, important considerations as we move into the implementation phase and planning. And before I move to those slides, I wanted to just review landscape analysis key takeaways quickly. So next slide, Julia. All right, we've gone through quite a bit of information very quickly. So reviewing the key highlights, we found that doulas are spread across Connecticut and many travel in geographic areas that end up covering the entire state. We found moderate diversity in the current doula workforce, but key groups are underrepresented, such as doulas who speak a language other than English. 73% of doulas that we surveyed are interested in serving Husky members. 60% of the surveyed doulas are interested in taking more clients. We know that there aren't enough doulas to serve all Husky members right now, but the timeline to scaling the workforce could be short with the right incentives, funding, and training plans in place. We know that doulas need access to training to meet the competencies necessary to achieve DPH certification and to best serve Husky members and flourish as small businesses. And we know that Husky members and providers need education about the scope of doula practice and training to help them understand what role a doula plays in a patient's care team. And the last thing is that doulas and providers need help building administrative infrastructure and capacity that doesn't currently exist to facilitate relationships through the bundled payment. Next slide. So with that in mind, we have started developing the implementation plan. So I will go through roles and resources next. So first, let's look at integration roles. Next slide. So through the maternity bundled payment, we know that all DSS, doulas, and providers all have a role to play in integration with serving the Husky Health member at the center of everyone's role. DSS's role in the maternity bundled payment doula integration will be to support the effort by providing the payment authority and paying the providers through the bundled payment program via the per member per month funding. DSS will determine the performance parameters and the specific reporting requirements for doula services, and they will have a fee schedule specific to doula services for the amount that will be paid to providers. As part of the doula implementation, DSS will provide draft supporting materials, which I'll talk about in the next slides. And as we talked about earlier, DSS is also pursuing a parallel direct payment pathway for doulas that's contingent upon DPH certification passing through the legislature. Although the payment pathways have some key differences, where those two payment pathways can be aligned, there is intention and motivation to do so. Providers in the integration effort will be responsible for creating the relationships with doulas, Providers will be able to define what type of doula program they want to create, whether it's a subcontractual relationship or they end up employing doulas. Providers should be the ones who are referring their patients to doula services. And we found that providers are a really strong and powerful referral source for doulas, and that in the Husky member focus groups, Husky members were really motivated when their provider recommended a service to them. So we think that this is a key area of growth for providers. Providers will also set their own doula payment rate, and they'll pay doulas when a patient uses doula services in accordance with whatever practice level doula agreements they have in place. Providers will also be responsible for collecting and reporting doula outcomes to DSS via the bundled payment encounter form. Lastly, doulas will engage with the program by engaging with providers directly, submitting their encounter information and outcomes to the provider as necessary to inform the encounter form completion, and invoice the provider directly for any services rendered. So we wanted to make sure that everyone understands that the payment route is from DSS to the provider and then a provider to the doula. But in this payment pathway, there is not direct payment from DSS to the doulas. Doulas will be responsible for reviewing the competency requirements and ensuring they meet them, although providers will also have a role to play in terms of determining which doulas their practice decides to work with. Next slide. So to facilitate all of this, we are developing a doula integration toolkit. This toolkit will be publicly available for all providers and doulas to use, and the components of the toolkit are forms, policies, and guides, which will serve as the building blocks for integration. And first, let's talk about forms and policies. The forms and policies are a series of templates that practices and doulas can review and adapt to their specific needs. Our intention is to lay groundwork that practices can more easily build from without completely starting from scratch, because what we heard from practices and from doulas was kind of hesitation and worry about the administrative burden of creating a relationship from scratch. The forms will include credentialing guidelines, which will be most useful prior to DPH certification, a referral form for providers to use when referring their patients, and that's what we envision will be the main pipeline in the early months of the program. A reporting form for doulas to use to ensure they're providing the necessary information to the practice for completion of the bundled payment encounter form and the questions that are specific to doula services. An invoice, which is intended to be sent from the doula to the practice for doula payment purposes, and a satisfaction survey that's likely to be sent to patients postpartum after their doula care has concluded. It could be embedded within the provider's usual postpartum survey, or it could be a standalone survey. The draft policies include a doula job description, which will help providers and practices understand a doula scope of practice. Draft hospital or provider doula policy to clarify the role of a doula. In our interviews, we found virtually no hospitals or providers have doula policies right now, so we know this is an area of need and interest. Guidelines for a grievance process, and finally a code and rate schedule so providers can easily communicate billing needs to doulas, and doulas can more easily bill using that fee and code schedule. Next slide. The toolkit will also have guides, and for members we'll have an FAQ document that kind of lists out a lot of the commonly asked questions, and then also definitely covers how to access the doula benefit. For providers, we will have how to participate in the bundled payment. This will be covered in a webinar that's planned for June. Information about the role of a doula, an FAQ document, and a payment flow example, so providers can understand how the monthly PMPM will translate into paying for doulas, and then how the retrospective reconciliation of the bundle kind of satisfies the full loop of doula payment. And for doulas, we'll have how to participate in the bundled payment, which again will be a separate webinar from the provider webinar, but will be a webinar planned in June. A resource list available for trainings to fill gaps in their competencies, and an FAQ document about participation. And that brings us to next steps, and I'll pass it back to Amy.
Great, thanks. You can go ahead to the next slide. So what we're up to next is really building out those tools that Claudia just talked about. And we want to do that in collaboration with some initial demonstration sites that will be combinations of a provider or a provider group and a doula or a doula group that want to come together and begin providing this service to bundle participants when the bundle begins to roll out. And to do that, utilizing these tools and guides and policies and adapting them to their individual practices. So we will be reaching out to some of you that we've engaged with already, and we have a good sense of some of the real kind of go-getters around the state who are already, working together, doulas and providers, to provide that team-based care. So we're pretty excited to lean into some of that and help provide some supportive infrastructure. So if anybody's interested, they can feel free to reach out to Claudia or myself. And like I said, we're going to be continuing to draft and refine those toolkit resources with a bunch of input. And we'll have the webinars that Claudia referenced in June, one for providers about, there will be additional training about the bundle itself, but there will be a specific training about integrating the doula benefit, and then a separate webinar for doulas about their role and how they can participate and partner with practices. Next slide. And then this is that same slide we started with. So just again, to walk more briefly this time through our key recommendations, and then we can take some questions shortly. A big area that we need to focus on is the workforce. There is sufficient workforce with capacity for year one if we have the expected utilization, but we really need to focus on growing that and making sure we have a diverse and representative workforce going forward. Reimbursement, we're going to be providing some pathways and tools to support that. There's also some infrastructure in place from DPH that we can leverage for the draft competency requirements, and we'll be communicating more about the specifics of the payments, but we are really trying to align with where the trends are going with adequate payment for the doula service. As far as practice integration, we're looking at somewhere likely between 5 and 10% utilization in this first year, focusing on kind of getting it right with these early implementation sites and building that infrastructure and the workforce for the growth from there. Encouraging adoption of doula policies, and continuing to provide education through these webinars and other opportunities for members, providers, doulas, and everyone. And making sure that providers are really tapping into a diverse doula pool and considering a third-party intermediary to support that integration. Next slide. Actually, I think that brings us to the end. We'll send these slides out, and they have a couple of appendix slides with additional information, or we can bring those up if they're helpful in the discussion. But I think we will turn to questions now, or Brad or Fatmata, I don't know if you have anything that you want to add.
Thanks so much. I was just going to add one thing about payment, because I know there's been some questions about it. So as of now, we have a set budget for funding that we're allocated between both doula and lactation support services. And we have previously discussed a $20 PMPM that would be for doula and lactation we were paying to providers. As far as in terms of the bundle on the back end, since we're doing this retrospective reconciliation, we've been able to kind of calculate that we can provide for doula services as part of the bundle $1,200. And so we've just wanted to say that we haven't officially set what the fee-for-service component would be. We assume it's going to be relatively similar to the $1,200 in terms of how the breakdown is, but we'll have more details to come on that. I did just want to make sure we said that out loud, just to kind of help frame, because I know the $20 PMPM may have been alarming to some folks. And so we'll be looking to kind of revisit this throughout the launch and in the first year in terms of rate and utilization. And so we just to say, we really appreciate the work that PMC has been doing with this, and we look forward to helping us try to get more doula utilization, both in the first year, but then also subsequently as we look to refine this over time. Fatmata, anything you wanted to add?
No, Brad, I think you covered it. That was the most important piece that we needed to cover. But just to concur what you said, I just wanted to thank PMC Health Equity Solutions for all the work that they did around this and will continue to do, and also our stakeholders, the advisory committee, for just being there with us and continuing this work. And hopefully, we will launch, a bundle and improve upon it in years to come. Thank you.
I have a question. How, if these doulas are rolled into the PMPM for the physicians, I'm just questioning, liability. Are they carrying, we didn't say, are they carrying their own professional, or they don't have professional, but are they carrying some level of insurance as we contemplate paying them? The question always will be on legal side, if there's an untoward event, does that constitute some kind of employment, loose or not, that we have to figure out how are we going to cover them from a liability perspective? Was there any review of that, Amy, from your team? Like, what do the doulas currently carry? Do they have any insurance? Obviously they need to protect themselves from, the variety of potential claims that could happen. So I was just curious, because I don't see that. And
yeah, I'll let Claudia speak to it. She's done a bunch of work in that.
Yeah, thanks, Paula. That was something that we heard brought up in a lot of interviews. So doulas do typically carry professional liability insurance, not medical malpractice, since they're not practicing medicine, but professional liability insurance. And that is a standard for other states that are developing fee-for-service payment, are requiring that professional liability coverage, just like any other enrolled provider. There are a couple key companies around the country that issue that professional liability coverage for doulas, and the policies are relatively inexpensive for doulas. We did talk a little bit about what the case history has been, and it's quite limited in terms of what cases have come up. It looks a lot different than what the obstetric practice case history looks like, of course. And in Connecticut, through the bundled payment, it will be a supervisory relationship. Because the provider on record will be required to supervise the doula services. That means that the provider sets the plan of care, and then the doula provides services within their scope of practice. And we did explore this question with one of the major insurers, and found that from their perspective, that was not problematic, assuming that whatever professional services agreement that the doula has in place with a provider, whether it's employment or if they're a subcontractor, like a 1099 relationship, it's just contemplated in your PSA, like you would do with any sort of other subcontracted service. And you define what's within a doula's scope of practice and what's outside of their scope of practice, and then they are covered with their professional liability. So for the purposes of this project, this question was something that we did look at, but we're not releasing a lot of information because it was determined to be slightly outside of scope. But what I can say is that doulas do typically carry professional liability, and we expect that practices would would have that as a requirement for any doula that they decide to work with. I think it's it would be industry standard at this point.
Thank you. think it's a lot to digest from a clinical practice, from a group practice or a physician practice perspective. I don't think we contemplated the PM component 100%. I'm just speaking for our large group. And the administrative piece of that, obviously is going to be something that we have to look at. How do we administer it? If it's 1 to 3 births a year, that's one thing. But when you have a good sizable portion of the deliveries and you look at that 5% number or less, I think we just have to think about this more collectively and figure out how we can administrate this in a way that makes it efficient for our practices. Again, I think about this and we want to make sure I appreciate that doulas can't carry an administrative burden that we have, because we have the infrastructure that exists today. And I appreciate DSS not wanting to add a lot of providers and having that administrative burden, but someone has to do it. And I think we have to think about how does that model work and within our organization as well, just given the staffing issues we're all seeing with administrative people as well as physician and provider resources. I think we're all facing those same challenges. So I think we just have to think about that more carefully.
Yeah, and we will have, a more provider focused training and then the opportunity through the demonstration sites. And we'd love to have, at least one Women's Health Connecticut site in there that we could really walk alongside you these next few months as these resources are coming together to figure out what does this really look like for practice.
Right. Yeah. And I think, we're more than willing to volunteer and be that group. Definitely know our level of interest in supporting this. I think it's just the details.
It's where the fun stuff happens, I think, is what they say.
Exactly. Right. How you define fun.
Larry.
So, hi everyone, Larry McGraw from CHN. So a couple of questions. Are there guidelines for which pregnancies a doula is appropriate for, or is it just assumed that, they could provide services in any pregnancy?
It's really been, demonstrated to be evidence-based for all types of folks. There's no group that it hasn't been shown to work for, in terms of effectiveness of some of the benefits like reducing C-sections and so on. There's been a lot of grant funded programs that have applied specific eligibility criteria because there's limited resources. And most of those are guided by kind of an equity mission to provide these services for people with the most need for support or with the most vulnerability for poor outcomes. And so there's been some interesting models that have, directed these resources at incarcerated people or, people with teen pregnancies and so on. And so we really don't want to apply eligibility for this in that sense. But we are looking at sort of what are some models for how to equitably distribute this resource in the first year. But to answer your question, it's good for everybody.
And I think, Amy, you probably answered my second question. I was going to ask if in the landscape analysis, there were studies showing what the benefits were, what the ROI on a program was in terms of outcomes.
Yeah, there's been
C-sections,
Yeah, so the benefits that have come out, there's a Cochrane systematic review that's been updated a number of times, and I don't have it in front of me, but I'm pretty familiar with it. So we see a reduction in C-sections, an increase in spontaneous vaginal births, lower use of epidural and other analgesia, higher breastfeeding rates, better or lower dissatisfaction with the birth experience.
Any impact on adverse maternal events?
There's some emerging models that have had more expanded doula support during the prenatal and postpartum timeframe, and those have less, I would say, rigorous and are randomized controlled trial type of studies, but they have some really compelling emerging evidence and data to support, for both mom and baby, actually, severe maternal morbidity events and outcomes like preterm birth and so on. And there's also been, there's a lot of emerging evidence that it can keep people keep people out of emergency rooms and antepartum and postpartum hospitalizations, those kinds of things. So and I can try to drop some links for folks that want to do a deep dive on some of that evidence.
If it's all right, I just want to add one, just in terms of Paula, kind of one of the things you were saying. Obviously, there is, to be a Medicaid provider takes, there's administrative, consideration for that in general. I think a lot of our desire to see doulas being utilized by members, and so that's the other reason we're pursuing kind of this dual path of both trying to have doulas paid through the bundle through providers, but also looking to have a fee-for-service direct payment option. Again, kind of allowing for the DPH process to play out, but just knowing that different groups may want to handle this differently. I think in the end, we're hoping to incentivize providers to work closely with doulas. So, there's a pay-for-reporting component for doula utilization in the first year that will impact shared savings. And in the long run, that's definitely a component that we think is extremely valuable that will hopefully impact, especially some of the health disparities that we've seen. And so we will definitely want to be looking at that utilization and how do we encourage that in the long run. And so just to say, we know we're going to be launching this, and just as the great work by PMC kind of shows you, there's going to be limited uptake in the first year just based off of the workforce. But over time, we hope we can incentivize growth of that workforce, as well as driving, encouraging providers to work closely with doulas, whether that's in a fee-for-service relationship or through the bundle, especially early on. So just to say, we will, we hope that there's some incentive to do this early, but we'll continue to look at this over time, given the impact we think it could have for our population.
What is the messaging going out to the doulas about the fee, Amy? I mean, do they understand the range of what we're setting, or where DSS is heading with this? You had mentioned that they're not objecting to it, provided that they have a mix of services to kind of offset them. Is that generally, do you think, the tone of everybody? Are they communicating with each other? So those that may not have participated in your focus group, if they come to us and say we're an interested party, like, I don't want our doctors to be the messengers about where we think the rate will be.
The only thing that's been announced publicly until this morning was the PMPM amount of $21, which was frankly like a head scratcher for people to try to take that amount and figure out what it would translate into in terms of a payment rate. And so I think that, anecdotally through our conversations, what we think is that $1,200 is a really favorable rate. Yeah. And I think that, we heard a lot of excitement from doulas, honestly, about the possibility of being able to serve Husky members. A lot of doulas that are serving Husky members currently, if they're doing it, are either taking it at a significantly reduced rate, much less than $1,200, or, even doing it as a free birth that they attend, one every 3 months or something like that. Okay. And so I think that there's a lot of excitement, and definitely at this point, don't expect any providers to be the messengers about payment rates, and that will be like formalized. Okay. But we also want to make sure, I think through the bundled payment, an important thing to point out is that the $1,200 is what goes to the practice, and then the practice will set their internal fee schedule for doulas. And so we also want to make sure that doulas understand that nuance.
Great, that's helpful.
Any other questions? We've got a couple more minutes. I can hand it back to Brad and Fatmata for any closing remarks or what's next.
Go ahead, Brad.
Thanks, Armand. Yeah, again, we appreciate, so it's lovely to see many of you again. We know you've been involved throughout this process, and we continue to appreciate that engagement and questions, and we'll be looking to have another meeting in May. Apologies again for the technical issues, and thanks to our Mercer colleagues for helping out in a pinch today. We'll be wanting to get this video up on our YouTube channel at some point as soon as we can, pending some technical challenges with, I'm sure, exchanging the video. But just to say, we know we have discussed a planned launch as of 7/1. We're internally kind of revisiting that time frame, and we'll be talking about it at the next meeting. So just plan on looking forward to that in May. And then again, just a thank you to our PMC colleagues who have really helped flesh a lot of this out. DSS recognized the need for additional support for dual integration work, which is why we sought additional support from PMC. And we appreciate the CHN team who's on here for helping execute on that for us. And so we know there's more work to be done, and we anticipate, as kind of with the entire bundle, with continuing to engage throughout this pre-launch as well as post-launch, because we know, one, we're not reaching everyone already that's interested in this, and two, there's going to need to be work done after we do this, including on the dual integration work. So just acknowledging that now. So thank you again. Fatmata or Guy, anything else you guys want to add closing?
No, thank you so much for the input. Sorry I was off camera. I didn't even realize with the technical things I was off camera for most of the meeting, but I learned a lot today, and I really appreciate the input and the time.
Yes, thanks to everyone.
All right, thanks everyone. Appreciate it. See you all soon.
Thank you.
Thank you. Bye-bye.
Thank you.